Welcome to the ESC studio. My name is Marco Valgimigli and I'm joined today by Professor Gilles Montalescot, who has been acting as a co-chairperson of the new ESC 2013 Stable Guidelines on Coronary Artery Disease. Welcome, Gilles.
Thank you for having me.
It's a pleasure. So, Gilles, can you walk us through the major novelties of this new document as compared to the previous one, which actually was released back in 2006?
Yes, Marco, there are a couple of things that are pretty new. First, we have updated this table, this old table from 1979 for the pre-test probability. So we have contemporary data to evaluate the risk of a patient presenting to the physician to have actually a stable angina. So we have data dating from 2011 now. So it's well adapted, and what we have seen is that actually the prevalence of coronary disease, especially in women, has decreased. So the numbers are different, and it's always the same. It's evaluated by age, gender, and the type of symptoms that you have, and you can make your own opinion on the risk of having the disease or not. So this is the first point. Second point is that we are using very much these imaging techniques now to do the diagnosis, the final diagnosis of stable angina, but also for the evaluation of prognosis. And this is very important because before sending the patient to the CAD lab, we need to be certain that we have the diagnosis of angina and that we have demonstrated ischemia, and probably that we have a certain degree of ischemia, probably more than 10% of the myocardium. And of course we can localize ischemia before we go to the CAD lab for coronary angio. If these exams are not contributive, or if you see a patient in the CAD lab without such demonstration, you still have the resource of using FFR in the CAD lab to evaluate if the stenosis are flow limiting or not. And this is very important because we don't want to provide revascularization to patients that do not need it. And the new aspects also are on the treatment side. We have clearly changed the ways we recommend drugs for stable angina. There are only two lines. A first line for the old drugs, beta blockers, calcium blockers, and a second line for all the new drugs, globally with a recommendation for all of them, which is a class 2 recommendation, 2A or 2B. And of course, in addition, there are these drugs that are important for the prevention of further cardiovascular events: aspirin, statins, ACE inhibitors in some patients. And of course, we have discussed revascularization. There are new data out there, you know, the important studies, Syntax, Barry2D, Freedom recently for the diabetic patients. And with all these studies, we have algorithms that help the physicians decide what kind of revascularization should be applied to such or such patient. And the last part of these guidelines is probably also important. We have looked at specific subsets: the elderly, the diabetic patients, the women, for example, that behave differently.
Thank you so much, Gilles. This is a really comprehensive document and we really look forward to getting to that more and more. Thank you so much for joining me today.
Thank you.
ESC Congress 365 is your free access to ESC Congress content all year long.